Hello, welcome to my channel. So today we are going to go through endometrial cancer. So endometrial cancer, in terms of definition or in terms of introduction, it's one of the common causes of postmenopausal bleeding. Okay, and the incidence of this malignancy has actually risen by approximately for about 40% over the past 20 years, which has been attributed to an increase in obesity during this period. Okay, so we can now go to the actual definition, which is endometrial cancer. This is a carcinoma that arises from the endometrial region, or it's a carcinoma that arises from the endometrium. Okay, then in terms of etiology and pathophysiology, so the most common form of endometrial cancer is adenocarcinoma, and which is a neoplasia of epithelial tissue that has granular origin and or granular characteristics. Then most cases of adenocarcinoma are caused by stimulation of the endometrium by estrogen without the protective effects of progesterone, which of course is termed as an unopposed estrogen. So prolonged exposure to estrogen or unopposed estrogen, especially when someone has actually never gotten pregnant before. Okay, so nulliparity, that causes unopposed estrogen. Okay, then you have to know that progesterone is produced by the corpus luteum after ovulation. Then scenarios in which women have experienced a longer period of anovulation are thought to predispose to developing malignancy. Okay, then unopposed estrogen can also cause endometrial hyperplasia. So this in itself is not malignancy, but can predispose to atypia, which is a precancerous state. Okay, then for the risk factors, we have number one is anovulation. So these are women who experience a prolonged period of anovulation and therefore exposed to unopposed estrogen and are at a greater risk of developing endometrial CA. So what are the risk factors for anovulation? So number one is menac. Or what are the other risk factors that can lead someone to having an unopposed estrogen? So number one is menac and or late menopause. So at the extremes of menstrual age, menstrual cycles are more likely to be anovulated. Then low parity, so just under 1/3 of women developing endometrial cancer are nulliparous. So with each pregnancy, the risk of endometrial cancer decreases. Okay, then apart from that, then we have polycystic ovarian syndrome, where patients present with oligomenorrhea cycles and cycles that are more likely to be anovulatory. Then we can have hormonal replacement therapy with estrogen alone. That can predispose someone to having anovulation and hence endometrial cancer. Then also tamoxifen use as well. Okay, then the second risk factor is age. So where the peak incidence of endometrial cancer is between 65 and 75 years, and prior to the age of 45, the risk of endometrial cancer is low. So that's why we said it's one of the causes of postmenopausal bleeding. It's because it's more common for people who have attained menopause. Okay, but below 45, the risk is low. Then for obesity, it is approximately 40% of endometrial CA cases are thought to be linked to obesity. Then the greater the amount of subcutaneous fat, the faster the rate of peripheral aromatization of androgens to estrogen, which increases unopposed estrogen levels in postmenopausal women. Okay, then we can also have the last factor, which is hereditary factors, where we have genetic conditions that predispose to cancer, such as hereditary non-polyposis colorectal cancer, which is known as Lynch syndrome, which are a risk factor for developing endometrial cancer. Okay, then for clinical features, then the clinical features, we have the main clinical feature of endometrial cancer, which is postmenopausal bleeding, okay, which is defined as bleeding 1 year after periods have stopped, or we can say this is postmenopausal bleeding is bleeding after established menopause, which is, and where we of course know that menopause is when 1 year passes without having periods. 24 months passes without having periods. That's now we can call it has been established. Okay, the majority, which is about 75 to 90% of women with endometrial cancer, of course, present with postmenopausal bleeding. However, this is also a non-specific symptom, because 90% of women with menopausal bleeding do not have endometrial CA, because they are, of course, postmenopausal bleeding is not only caused by endometrial CA. So uncommonly, postmenopausal women with endometrial malignancy may present with clear or white vaginal discharge or with abnormal cervical smears. Then endometrial cancer can also rarely develop in premenopausal women and may cause irregular bleeding and intermenstrual bleeding. Advanced or metastatic endometrial cancer may manifest with abdominal pain or weight loss. Then on examination, there will be on abdominal examination for abdomen. You can examine for abdominal or pelvic masses. Then speculum examination, there may be evidence of vulvar or vaginal atrophy or cervical lesions. Then for bimanual examination, you have to assess the size and axis of the uterus prior to endometrial sampling. Then for differential diagnosis, the main presenting symptom of endometrial cancer is postmenopausal bleeding, and these differentials are vulvar causes. So you can have a vulvar atrophy, vulvar premalignant or malignant conditions. You can have cervical causes such as cervical polyps, cervical cancer. You can have endometrial causes such as endometrial hyperplasia without malignancy, benign endometrial polyps, endometrial atrophy. These are some of the differentials. Then this is just a picture of a endometrial polyp, which is also a differential for postmenopausal bleeding. So this is a polyp, a endometrial polyp, and the following picture is one for a smear when they are doing cervical cancer screening for endometrial cancer, for cervical cancer really. Okay, then for the investigations for endometrial CA, so in transvaginal ultrasound is the most widely used first-line investigation. Then 96% of women with endometrial cancer will have an endometrial thickness of more than 5 millimeters on ultrasound. Then if an endometrial thickness of more than or equal to 4 millimeters in a postmenopausal woman is identified, then endometrial biopsy should be obtained. So this can be performed at an outpatient appointment, often with a prepared biopsy. Then histology from the biopsy can confirm the presence of hyperplasia with or without atypia or malignancy. Then if the gynecologist deem the case high risk, such as heavy bleeding, multiple risk factors, or very thickened endometrium on ultrasound, then the patient is unable or the patient is unable to tolerate outpatient sampling, then hysteroscopy with biopsy may be performed either as an outpatient or under anesthesia. Okay, then if the endometrium is less than 4 millimeters and appears normal on ultrasound, it is reasonable to defer endometrial sampling as the risk of cancer is low. However, if they continue to have abnormal bleeding, then sampling may be indicated. Then if the malignancy is confirmed, then an MRI or CT scan may be used for staging. So prior to any operative intervention, baseline blood investigations such as full blood count, urea and electrolytes, liver function test, and a group 1 self sample should of course be taken. And there are other things you can do as well. Okay, then how do you stage the endometrial cancer? So we use the FIGO staging, which is the most widely used staging system, FIGO staging. And FIGO, if you don't know what FIGO stands for, it stands for International Federation of Obstetrics and Gynecology. Okay, then we have for stages, we have stage 1, where the carcinoma is confined within the endometrial body. Then we have stage 1A and stage 1B. Then stage 1A, this is where we have, it's defined to the uterine body, but stage 1A is defined to the endometrium alone. Then stage 1B, it goes into the myometrium. So stage 1A, endometrium, stage 1B, myometrium. Then stage 2, this is where we have the cancer that may extend to the cervix, but it is not beyond the uterus. Then stage 2, that's how you define it. So it's defined to the cervix but not beyond the may extend to the cervix but not beyond the uterus. Then stage 3, the cancer has extended beyond the uterus but is confined to the pelvis. Then stage 3, we have stage 3A and stage 3B and stage 3C. Okay, for stage 3A, this is where the cancer has now gone to the ovaries. Then stage 3B, the cancer has gone to the vagina. Then stage 3C, the cancer has now gone to the lymph nodes. Okay, then stage 4, this is when the carcinoma involves bladder or bowel or has metastasized to distant sites. So specifically, we have stage 4A and stage 4B. So stage 4A is when the cancer is just within the surrounding pelvic organs. So it has either stage 4A, it has either gone to the bladder or bowel. Then stage 4B, it has now gone to distant sites such as the liver. Okay, that's stage 4B. Okay, then for management, so management is tailored at what exactly we are dealing with. So if you are dealing with endometrial hyperplasia, which is a non-malignant, if it's a non-malignant, simple or complex hyperplasia without atypia, we can be treated with progestogens such as Mirena, intrauterine systems, and a surveillance biopsy should be performed to identify any progression to atypia or malignancy. Then if you are dealing with an atypical hyperplasia, which has the highest rate of progression to malignancy, it should be treated with total abdominal hysterectomy plus bilateral salpingo-oophorectomy. Then if this surgery is contraindicated, the regular surveillance biopsy should still be performed. Okay, then for endometrial cancer, the management typically offered in endometrial carcinoma is dependent on the stage of the cancer. So if you have stage 1, then you can do total hysterectomy and bilateral salpingo-oophorectomy, and we do peritoneal oceans should also be taken. Then traditionally this has been performed as an open procedure, but laparoscopic surgery is increasingly performed. Then 75% of women present with stage 1 disease, and this has a very good 5-year survival rate of 90%. Then for stage 2, then you can do a radical hysterectomy, whereby the vaginal tissue surrounding the cervix is also removed alongside with the supporting ligaments of the uterus, and assessment and removal of pelvic lymph nodes, which is lymphadenectomy. Then women with confirmed carcinoma stage 1C or stage 2 may be offered adjunct radiotherapy. Okay, then for stage 3, we can do maximal debulking surgery if possible. Then additional chemotherapy is usually given prior to radiotherapy. Okay, then stage 4 they say maximal debulking surgery if possible. Then in many stage 4 patients, e.g. In many stage 4 patients, a palliative approach is offered, such as with a low dose radiotherapy or high dose oral progestogens. Okay, then a recurrence of treated carcinoma is possible, and so frequent follow-up is required up to 5 years post-operatively. So that's all on endometrial cancer. It's a very good topic. It's a very nice topic, and if you haven't subscribed, please subscribe and hit the bell notification and check out other videos on the channel. Okay, then and see you on the next tutorial.